Yes, very good. Not only for neonatal meningitis, of course, in neonates, you have to have the highest degree of suspicion. For all cases of childhood meningitis, symptoms and signs can be vague. So therefore, you must have a high degree of suspicion, right? Okay, good. So that's the pearl. Now, you all are very good at collecting pearls. So let's see what you can gather at the end of these two lectures. It's actually two lectures. So we are going to talk about two different areas. You'll realize that it's a bit interconnected. So we'll be talking about hydrocephalus, and then we'll speak about neural tube defects. Okay. Right. Okay. So these are the learning outcomes of the first one. We'll have to define and classify hydrocephalus. Then we will have to understand the causes and the clinical features of hydrocephalus in children. Mind you, this is in children. Then let's discuss the evolution of a child with hydrocephalus, what happens thereafter. And then we, try to match it with the development of hydrocephalus in neural tube defects. And then also we try to discuss the evolution of a child with neural tube defect, including the acute management and the long-term follow-up, right? So that's what we would be talking about. So let's first start by understanding what hydrocephalus is. Now, can you show, raise your hands if you have seen a baby with hydrocephalus? You can raise your hands in this so that I can have a look. Okay. Good. Very good. Okay, so you have seen what it looks like. So let's try and understand how we identify it, how do we classify it, then how do we get about it, right? Okay, so what's the definition? And then we go to classification. The definition is that there has to be abnormal buildup of CSF fluid, right? And this abnormal buildup of CSF fluid has to be within the ventricular system within the brain, right? So that's what you call hydrocephalus. And that can be caused by three different problems. It can be caused by disturbance of formation of CSF. It can be caused by a disturbance of the flow of CSF, or it can be related to a problem in the absorption of CSF. Okay, right. So let's move on. Okay. Can somebody explain? This is just the normal physiology. Can I invite one of you to describe through the normal physiology? Can you tell me what happens? Can you tell me what happens here? What does this show? What happens here? What is shown here? Anybody? Divining? Anybody?
Choroid plexus.
The production of spaces by the choroid plexus.
Okay. So this is the place where the CSF is produced, right? So here I have enlarged it for you. You can see the capillary bed. You can see the seepage of this fluid through the tissue lining. These are the villi, and then it seeps through into the ventricle. So you can see that the CSF then flows into the ventricle. So thereafter, through the ventricular system, the CSF flows, and then subsequently CSF flows out into the subarachnoid space, and then in the end, it is absorbed through the arachnoid granulation. So these arachnoid granulations are small outpouchings of the subarachnoid space. You can see them here, like small, outpouches, and through this, the CSF passes and gets absorbed into the dural venous sinus. So it's produced here, it flows, goes out into the subarachnoid space, and then through the arachnoid granulations, it gets absorbed into the venous sinus, right? So that's the normal physiology. Right, now let's understand what happens in production of CSF, formation of hydrocephalus. Okay, now somebody, was it Sachini? Yeah, Sachini very nicely showed the ventricles in the previous lecture. Can somebody tell me the flow through the diagram, right? Can somebody tell me what happens to the CSF? We showed you, basically showed you the production, then I showed you the flow and then the absorption. But then can you tell me what happens through the ventricular system? Sachini, can you have a go?
Okay, madam. So the CSF is produced in the third ventricle and part of the fourth ventricle, and it can
Where is it, where do you find the choroid plexus? Or it's found in several places, but
all of the third
is it third ventricle
or the roof of the lateral.
Yeah, it's in the lateral ventricle, particularly in the temporal horn or the inferior lateral ventricle. So then what happens? So the CSF is produced, then what happens?
Then from the lateral ventricles, it
So
flows.
this is the lateral ventricle, so the inferior horn and the anterior horn. Some people call it is the frontal part. This is the temporal part. What happens next?
It flows to the third ventricle through
Goes
the
to the third ventricle through the
foramen of Monro.
foramen of Monro. Very good. Then what happens?
And then it flows through the cerebral aqueduct.
Yes. So this part is a cerebral aqueduct. Flows into what?
The fourth ventricle.
So you can see the fourth ventricle. So the cerebellum forms the roof of the fourth ventricle. Then what happens?
Then there are the foramen of Magendie and the
Yes.
foramen of Dushka.
Yes. And through which it goes into the subarachnoid space, right? Okay. So this is another cross-section because this is how you would see it often. You can see the anterior part of the lateral ventricle, and this is the posterior part. And if you go down into the temporal lobe, you'll find the posterior temporal horn of the lateral ventricle. And here you have the third ventricle, right? Okay, so let's have a look at what happens. This is what you explained. So there's production. And then after the production, then the CSF in the lateral ventricles flows through the foramen of Monro to the third ventricle. And then through the third ventricle, it flows through the aqueduct of Sylvius into the fourth ventricle. And in the fourth ventricle, you have the foramina, the foramen of Dushka and Magendie, through which it then flows out into the subarachnoid space. And then from the subarachnoid space, so it flows into the subarachnoid space. And then from that, I showed you the outpouchings. Then it gets absorbed into the dural venous sinus. So that's the normal CSF drainage pathway, right? Okay, very good. So here we have the normal drainage pathway, and then I showed you this before. This is the normal anatomy. If you have an axial section, and then what happens in hydrocephalus is there's accumulation of fluid within this ventricular system, right? So you can see in this diagram how beautifully you can see that there's obviously the ventricular system is dilated. And so how does that appear here? Can somebody talk through this? Can somebody explain what's shown here? Who is going to explain this? Have a go. Quick. What can you say about the lateral ventricles? What can you say about the lateral ventricle? What has happened to the lateral ventricle?
Enlarged.
Yes, very much enlarged. And then you can see it's, expanding into the white matter, right? What else do you see?
Salsa and gyri are not much clear.
Exactly. So Salsaya gyri are not much clear if you compare that with this. Here you can see, of course, this is a CT, this is a MRI, but you can see that there is enough space between the cortex and the dural lining. So there is plenty of space because you can clearly see the subarachnoid space. But here you can see that this is pressing on to almost to the surface. So the Salsaya and gyri are not very clearly defined, right? Okay, so let's move on to understand the classification of hydrocephalus. Now you have a basic picture, and also we had a beautiful case, a clinical case, which was described in the previous lecture. So we should be able to understand the types of hydrocephalus. So basically we divide them into two groups. We call them as communicating and non-communicating. What you mean by communicating is that there is a connection between two ends, right? So If the ventricular system continues to be communicated, we call it a communicating hydrocephalus. And if the ventricular system, one end is not communicating with the other end, or some parts of the ventricular system is not communicating, then we call it non-communicating. You might sometimes find in the older literature, they use two different terminologies. Communicating means there's, nothing obstructing the flow from one end to the other. So therefore, it's non-obstructive. But non-communicating, those days it used to be called obstructive because the pathway is obstructed, right? So that should make it easy for you to understand. So let's start with the easy one. Can somebody give me an example for non-communicative hydrocephalus? It's non-communicating. The ventricular system, is there some, something makes it not to communicate from the rest of the system. Example, please. Can somebody
Tumor
shout?
obstructing the pathway.
Yes, tumor obstructing the pathway. Can you give me an example of a tumor? What kind of a tumor can obstruct the pathway, Hiroshan? At least a place?
Tumor somewhere surrounding the cerebral aqueduct.
Yes. Okay. Yes. Possible. Common one would be medulloblastoma. Now, medulloblastoma rises from the cerebellum, and you remember I showed you that the cerebellum forms the roof of the fourth ventricle. So, therefore, when there is medulloblastoma, it presses onto the fourth ventricle and causing obstruction to the outflow. So non-communicating one, there is a obstructed CSF flow, and depending on the place where the obstruction is, you will find parts of the ventricular system ballooning. So you might find that if the aqueduct is blocked, you'll find the lateral ventricles ballooning and the third ventricle ballooning. If the fourth ventricle is obstructed, then you will find part of the aqueduct also becoming prominent. And if you have a spinal tumor, then of course you'll find all four ventricular systems ballooned out, right? So depending on where it is blocked, you will find the imaging differs. In a non-communicating one, can you tell me an example of a non-communicating one? You had a beautiful example shown a little while ago. So in non-communicating, the problem is actually not because of the pathway is blocked, but a different mechanism. So you remember it's a production, it's a flow, and the absorption. In communicating, often it is the absorption which is affected. What was the example that we discussed a little while ago in the previous lecture?
TB.
TB meningitis.
TB, yes. How does TB cause a communicating hydrocephalus? What gets, which component? It's the production, flow, absorption, which gets affected?
It's the production as well as the absorption.
Predominantly, which one? Where did you see that, nice,
Production.
is it the production? You saw lots of inflammatory exudate. It's like a star which was sitting there. You saw the non-contrast CT and the contrast CT. What do you think the inflammatory exudate does?
It prevents the absorption of the...
Yes, it causes arachnoiditis and therefore it prevents the absorption, right? So TB meningitis is the best example so that you would never forget what a communicating hydrocephalus would look like and how it is formed. So if you have hemorrhage, same thing happens. And then if you have meningitis, bacterial, particularly TB meningitis, you can have communicating hydrocephalus, right? Okay, so let's move on. So these are some of the examples. I think we went through these. These are the non-communicating ones, which can be congenital because of pathway obstructions like aqueduct stenosis, or you can have what you call a dandivocosis, where there's a large cyst in the posterior fossa, which is here. You can have a large cyst here, and the cyst actually compresses the ventricular system, so there can be hydrocephalus, or in the case of acquired causes, you can see there's this large tumor here, like for example, the medulloblastoma, which causes compression of the fourth ventricle. So you see ballooning out of the third ventricle, and also you see ballooning out of the lateral ventricles. Okay, so is that clear? The classification, any problems? Is that clear? Can we move on? Okay, any questions? Right. Okay. So now then we move on to understand the clinical features of hydrocephalus. Now, clinical features, we are talking about clinical features in children. If you may get clinical features, if you get hydrocephalus, the clinical features are different. Okay. Because our skull is formed, we don't have fontanelles, we don't have, sutures which can get separated. So therefore, the clinical features are very much different according to the age group. So in older group, obviously you get early signs of raised intracranial pressure. So you would have clinical features of headache, vomiting, features of raised intracranial pressure. But in the younger age group, because their skulls are malleable, they have time for it to expand, and the sutures are still not fused. So therefore, there is a lot of time for it to expand. So there would be some kind of a delay in the presentation with hydrocephalus in the younger age group. So obviously, so it may be notoriously variable, and initially in children, they can be asymptomatic. But however, the symptoms can then even progress to lead to death. So depending on the age of the patient and the rapidity of development of the physical signs or the cause. For example, if it's TB meningitis, then it might take us, it's not in, few days. But if it happens to be a subarachnoid hemorrhage, it can be a very rapid involvement. If you're talking about tumor, if it's a slow-going tumor, it takes a long while. If it's something like glioblastoma multiforme, it can be rapid. And aqueduct stenosis is something where they can be having it from birth, and then gradually the ventricular system enlarges, and then you detect the hydrocephalus when the baby presents because of enlarging occipitofrontal circumference. Okay. So depending on the age, depending on how rapid, and depending on the cause, this presentation of symptoms may be variable. Okay, so therefore, at least I have divided them into the clinical features in young, very young, and also then in the older group. So I've divided them into two groups. Obviously, the first group is related to raised intracranial pressure, right? So in the younger age group, the presenting features would be irritability, poor feeding, lethargy. And then the other set of clinical features are because of the enlargement of the head, right? So you can see a physical enlargement of the head, you can see suture separation, you can see widening of the fontanelle, you expect the fontanelles to close, and then instead you find that they are open, they are wide, they become more wide, and then you will also find the fontanelles bulge, right? Then they can also have what we call, because of the causes, the increase, the hydrocephalus, the pressure causing effect on the colliculi, it will limit the upgaze. So therefore, instead of upgaze, the eyes would be forcefully moved downwards, which would then, result in what we call a sunset sign. So I'll show you an image, and that is because of the limitations posed to the upgaze because of compression on the colliculi. So you can also, because their skulls are very thin, you can shine a torch and then it'll look like a Chinese lantern. And also you can have very prominent tortuous scalp veins. So if the children are older and in adults, then of course the clinical features would be they'll complain of headache. There would be, signs of raised intracranial pressure like nausea, vomiting, and they can even experience seizures. They can become drowsy. They can have visual disturbances because of compression on the optic nerve. They may have features like ataxia. They can have papilledema. Then you can develop false lateralizing signs. The gradual evolution of hydrocephalus would result in things like slow mentation, gait disturbances like particularly normal pressure, hydrocephalus, visual disturbances, papilledema, incontinence, and even dementia. Right, so there's a variable spectrum of clinical features depending on the age, depending on the cause, that is the rapidity of development, and the placement of the underlying cause of hydrocephalus. So these are some of the physical signs that you see in the younger age group. So I have shown here enlarging head, the large head size, and you can also see the bossing, right? The frontal region is significantly larger And you can see that the head shape, like you can, I think, appreciate it much better in this image. You can appreciate it here. It's like an ice cream cone, like, it's like a, top end is like a cone, and then you find that the top end is the larger, and the face becomes, it's like in the shape of a funnel. So you can see the dilated veins which are seen on the surface here. The skull is shining, and if you palpate, you can palpate the anterior fontanelle, and here the anterior fontanelle is actually bulging. So therefore, and here in both this image and this image, you can clearly appreciate what you call the monosign. What do you call this?
Sunset.
Sunset. Does it look like the sun setting? Yes, right. When the sun sets, the sun goes down, right? So here, this is because of the upward gaze palsy. So the baby is unable to look up, and not only that, it actually causes a forceful downward deviation. So therefore, the eyes are, forcefully pushed to look downward. So therefore, this causes what we call the sunset sun, right? So, and if you shine a light, because, the baby's skull is very thin, you can see this trans illumination. And sometimes, because of the water collection, particularly in those who have chronic hydrocephalus for a long time, during our Urdu season, everybody goes and taps on those, pots, and hear, listen to that sound. Not that I have ever heard this pot sign, but it's like the sound that you get, when you tap to a cracked pot, right? So that is also one of the physical signs that is described in children who have hydrocephalus. Don't ever forget to examine the back. Now, can somebody tell me why? You look at all these physical signs, but you have to look at the back. Can somebody tell me why? Why do you have to look at the back?
Associated with neural tube defects like spinal bifida.
Exactly. Who was that?
Beneath, ma'am.
Good, excellent. Yes, so it can be associated with neural tube defects, which we are going to talk about later. So that is the cause of the hydrocephalus. So obviously, it's causing an obstructive hydrocephalus, but the obstruction is at the lower end of it's not exactly the ventricular system, but it's in the CSF pathway, because obstruction to the the flow through the subarachnoid space. So yes, so you had to look at the back. So you have to look for evidence of neural tube defect. So how else can you now I said it depends, the clinical signs depends on the cause of the hydrocephalus, and so there are causes which are very slow to manifest clinical signs. So one of the ways how we detect that is, even before the child starts developing nausea and vomiting, which is at the upper end or later stages, this is by following up on the occipitofrontal circumference. So you can see how the occipitofrontal circumference is crossing centiles and gradually enlarging to above the 99th centile. So this is a clear case of an aqueduct stenosis. So it's not an absolute stenosis. The aqueduct is there. There is CSF flow. So in the early age, the CSF production is not as much as in the later stages. So as the baby grows, when the CSF production becomes fully established, you realize that the size of the aqueduct is not enough for you to maintain the CSF flow, right? So this would be how we detect a possible underlying aqueduct stenosis in a baby, or maybe a tumor, when the OFC is enlarging like this. Okay, right. So how do we manage? So obviously we follow up, like what I showed you in the previous in the graph. If the baby is not symptomatic, we wait to see whether the CSF production and the outflow stabilizes. So we're not going to go in immediately, but of course, if there is a need, then we need to create another alternative path through which the CSF flow can be bypassed. So part of your evaluation would be your evaluation of a suspected hydrocephalus. You may also, when you go to the antenatal wards, you might, sometimes hear when they perform the antenatal scans, they detect hydrocephalus. So really speaking, in some of those congenital causes, management actually starts even in utero. There are cases where they perform in utero electrosurgery as well, not in Sri Lanka. So actually management follow-up starts from utero in some other cases. So there would be regular ultrasound monitoring. I'm talking about the pediatric early onset cases. So I've already mentioned about the fetal surgery, and then, okay, you detect it even after birth. You initially keep monitoring the head size, because unlike in older people, in babies, there's space to enlarge. Therefore, they may not become symptomatic. So we have some time to understand what is happening, what is causing, is there a reversible, or is there a cause which may stabilize, where we may not need to go in and perform a surgical intervention. So if the OFC is gradually increasing, and then of course we may have to place a shunt if you find that the ventricle system is gradually enlarging, right? And of course you may have to treat the underlying cause, right? So this is early hydrocephalus. So it's a young age. If you have a late hydrocephalus, you have the signs of raised ICP. I've already told you why it comes on early. You may have to treat the ICP. You may have to insert a BP shunt early and manage all these other complications, right? So the management is slightly different according to the age of the presentation. And of course, you already know why that is, right? Okay. So same thing. That's why I said, when you're performing lumbar puncture, you don't have to worry about herniation, because there's plenty of space. It doesn't herniate down. There is enough of space for it to expand. There's all sutures are open. So you don't really worry too much in the young age about herniation. Similarly, in hydrocephalus, you now understand why I made that statement. So they have time, they can expand. So there is time taken to establish features of raised ICP. Okay, so you create a bypass. This is how you create the bypass. You obviously through a drainage system. So you have 3 parts. You have the ventricular component. This is what goes into the ventricle. So you have a valve so that you control the drainage, and nothing from this side goes into the ventricle, because then it causes infection. So there's only an outward flow, and of course this then goes into different sites, different collection sites. So it can be the peritoneum, which is the commonest site, which can expand and accommodate a larger volume. It can even be pleura. It can even be the pericardium as well, right? Okay, so this is the 3 parts. So ideally, if you use a silicone, elastometer shunt, that's good. But what we often have are we don't even have the valve, which is here, right? So, and even better would be if you can have what we call a programmable shunt, because when we have the valve, what we know is the direction is from inside to outside, but I can't control how much is going outside. So if the ventricles are at significant pressure, I don't have a clear-cut way of controlling. But if you have a programmable shunt, the what you call aperture of the shunt is externally programmable. So I can decide how much do I want to open and how much do I want to control the flow outward, so that we don't have sudden collapse of the system, nor do we have too slow drainage of the hydrocephalus. Right. Okay. So one important clinical thing now, as house officers, as attending physicians, we must know how to check whether the shunt is working or not. Right. Now, has any one of you seen, the neurosurgery MOs coming and checking to see whether the shunt is working? Do you know how they do that? What do they do? Has anybody seen that? Anybody? Do you know what they do to check whether the shunt is working? You may appreciate that from externally, you can feel this valve, right? So it's like a bulb. You can feel it outside, and the bulb is compressible, right? So let me show you. This is what is normal. So the bulb is palpable. You can feel it from outside. So when there is a shunt, you first try to see where the valve, or where the valve is situated, right? So then you exert pressure on the valve. So you already know that you can't have anything going from outside to inside. So this is inside and this is outside, right? So therefore nothing goes inside. So if it is working normally, when I compress, whatever the CSF that was inside the bulb has to flow out into the outward flow, into the peritoneum. Okay. And then what happens? It then refills again, because the pathway from inside is intact. So this is a normal ventricular peritoneal shunt. The bulb is okay. Inside intraventricular catheter is functioning. Then from the outside catheter is also outflowing. So this is normal. When we have a problem, the problem can be that there is obstruction because there's no CSF is coming from inside to outside. Okay. So what happens is when I compress, the CSF flows outwards, but then nothing fills up, right? So then we realize the problem is actually from inside. The opposite is seen when there's an obstruction, outflow obstruction. So here, the CSF does not flow outside. So therefore, when I compress, it doesn't get compressed because the outflow is obstructed. So this is something that you have to be familiar, because when you're asked to find out whether the valve is working, you need to be able to say this, right? So this is just a very important clinical pearl. Right. Okay. So management, of course, I already told you, management includes management of complications. You can have mechanical failures, you can have infection, and you can have functional failures as well, right? So mechanical failures are obstruction. The catheter can migrate, it can get disconnected, it can rupture. Then the more common complication is actually infection. You can have functional failures. I already mentioned a few. You can have under drainage, you can have over drainage, you can have cyst formation, then you can have too much of fluid coming into the abdomen and it causing ascites. It can cause cysts in the abdomen. So many things that can happen as complication, right? Okay, right. So before we move to the next part, a few MCQs. Now I want you to shout out the answers. Regarding hydrocephalus in children, it is caused by enlargement of the head circumference. True or false? ටට්ටක් ගාලා කියන්න. It is caused by enlargement of the head circumference. Fire. Oh,
False.
false. That was a Sachini. Yes. Why? Why is it false?
It causes enlargement.
It causes enlargement, yes, agree, but that is not the cause. The cause has to be with the ventricular system. It can enlarge because of many other reasons. It can be something like hypothyroidism, which is causing a macrocephaly. So head enlargement per se is not the cause of hydrocephalus, but head enlargement can happen in hydrocephalus. Okay. Bacterial meningitis causes communicating hydrocephalus. True or false?
True.
True. Good. Occurs in torch infections.
True.
True. Binet, yes. Which one?
Toxoplasma.
Toxoplasma, yes. Right? Toxoplasma causes hydrocephalus. The fourth ventricle is enlarged in aqueduct stenosis. You all explain how the CSF flows. So now you have to tell me false. Which one becomes enlarged?
Third
Only the third?
and the lateral. Third and lateral.
Third and the lateral. Right. Okay. It's treated by inserting a ventricular atrial shunt.
True.
True. Yeah, that's correct. Yeah. Okay, let's move on. Now we move on to neural tube defects, right? So a little bit of anatomy as well, a little bit of embryology. So broadly, when you talk about neural tube defects, right? So you can have different types of neural tube defects. You can have neural tube defects which involve the brain. Often what we call, you can have anencephaly. So if you consider the bone, which covers the brain and the skin, that also to be part of the neural tube, then it can cause in the upper end anencephaly, and then in the lower end, what causes is, we call it spinal dystrophism. Okay. So it's relatively rare. So overall, about 1 in 1,000 pregnancies can get affected with neural tube defects. Anencephaly is rare in comparison to spinal dystrophism. So spinal dystrophism, when you take that, the most common site is the lumbosacral region. And usually, generally it tends to involve about 2 to 3 vertebral segments. Right. So a little bit about how it develops. This is histology. You would, from your initial days, you'll remember that you have the ectoderm, mesoderm, and the endoderm. So endoderm is not involved here, so we just move it out. So when you take the ectoderm or the most superficial lining, so the neural plate is actually formed from the ectoderm, right? In the ectoderm, there is a structure which is called the notochord, which becomes a stimulus for the migration of part of the ectoderm. So the migration is, you find that, the ectoderm follows in the direction of the notochord and it migrates downwards. So therefore, when the neural tube migrates downwards, the ectoderm, it has two parts. There is this border area, which you can see as this, light green area, which you call the borderline region. So the neural plate invaginates inside. So the borderline region comes together. So borderline region comes to the center. Initially, the neural plate completely, separates from the borderline region and the neural crest. So borderline region and the rest of the ectoderm. Borderline region forms the neural crest, which also then goes invaginates, and that is what forms the peripheral nervous system, and then the ectoderm connects together to form the skin layering, right? So this is what happens. So the neural tube formulates the spinal cord, and then the rest of the structures like the neural crest forms the peripheral nervous system, which includes you have the parasympathetic nervous chains, which is also coming from the neural crest, and then you have the skin overlay. So this is what happens normally, right? So when this process is interfered, only we find that there is formation of spinal dystrophism, or for that matter, when it happens in the superior part, which is very less common, we call it anencephaly. So when you talk of spinal dystrophism, there can be different forms of severity. Now, this is the normal spinal cord. So you have the dermal lining here. Then, when part of the soft tissue, the part that forms the soft tissue gets disrupted, we have what we call spina bifida occulta. So there is no the notochord does not get involved in the formation of the spina bifida occulta. But then when the notochord is affected, then you have actually rather three forms. Spina bifida myelochesis is that the entire brain and the whole of the spinal cord is out. So that's a very severe form. We hardly see this. Most often what we see are these two forms, which is called the B and the C, which is depicted in the diagrams here and here. In B, what you find is it's just only the coverings. It's only the coverings which invaginate, right? So this is what you call meningocele, right? It's only the meninges, so forming a cyst. So it's a meningocele. But in the most severe one is what you call meningomyelocele. You know that myelo means the spinal cord. So spinal cord components, which includes the chorda equina, can get invaginated into the sac, which is lined by the dura, right? Which is lined by the meningeal coverings. So these are the two forms that we see. This is what we don't see. This is what we see. This one has definitely good skin coverage, and also it's just the dura which has invaginated. This one may have complete coverage or may not have complete coverage, or it may just have a very thin wall which gets easily ruptured in the process of delivery, right? So these are the ones that you have seen. So depending on what is involved, you will experience physical signs. Okay, right. So etiology. So the precise cause is there's no one definite cause. Often it has a polygenic inheritance pattern. So some of the risk factors, these are risk factors and not definite causative factors. The definite causative links that have been shown are the ones that I have shown in bold. That's inadequate maternal folic acid intake, maternal obesity, and parental exposure to this particular agent has been linked with a definite risk of developing neural tube defects, but the others are implicated risk factors like female sex, family history of neural tube defects. So if you have one child who has a neural tube defect, we have to be very cautious. We have to suspect possibility of recurrence later in the next offspring. Also, the use of anti-seizure medications, because some of the anti-seizure medications are directly linked, some through interference with the folic acid production, folic acid metabolism pathway. So these are some of the links, but the definite risk factors are the ones that I have outlined in bold. So let's talk about the clinical spectrum. Now I have already shown you, 3 different clinical spectrums. The spina bifida occulta, that is what happens when there's a problem with the mesoderm, right? So, sorry. If when the mesoderm is affected, you can have vertebral involvement. So you can have all these vertebral abnormalities. You can also have these other mesodermal structures being affected, right? So because the mesoderm forms the non-neural supportive tissues, or any of those supportive tissues can show abnormality, right? So you can have like the phylum terminale can become thick. You can have fat, which is causing like a seal. Then you can have bone, which is going inside. And then sometimes the skin. The skin can formulate connections with the internal structure. So these are all mesodermal abnormalities. So you can have either mesodermal structures abnormalities only, or you can have mesodermal structures abnormalities concurrent to abnormalities of the ectoderm as well, right? So I already showed you how the neural ectoderm formulates the spinal cord, and then when there's a problem, you can have either open or what you call the spinal dystrophism that I showed you as meningocele, meningomyelocele, or myelokesis, right? So these are the 2 different forms of presentation depending on which part of the primitive structures are involved. So depending on that, this is just an expansion of what I just mentioned. This is what we see on the surface. So you have open spinal dystrophism, then the other parts are closed spinal dystrophism. Same as the previous slide, if you have the subcutaneous tissue involved, you have these structures which are involved. And if you don't have the subcutaneous tissue, but you have vertebral abnormalities, then you can have these simple and complex dystrophic patterns causing the abnormal presentations. Okay, right. So this is just the clinical classification of neural tube defects, stemming from the understanding of the pathophysiology, stemming from your basic embryology. Okay. Any questions up to that? 419. Yeah, so let's move on. So the clinical features would be any of these. So it could be based on the appearance. It could be based on the severity. So depending on the appearance, it's very simple. You see a lump at the back. You can see lump elsewhere. Commonly, I already told you it's in the lumbosacral region. If it's occipital encephalocele, a milder version of the anencephaly is just encephalocele. Often we see it in the cervical region. And then with all this, if the mesodermal structures are also involved, you can have any of this. So you would actually look for these. You look to see whether there's hair, you see whether there's hemangioma. There can be just a dimple, there can be a sinus, there can be pigmentation. So all these abnormalities may hint of maybe a potential underlying ectodermal structural abnormality as well, right? Then your presentation can be based on severity. That's often the way how they present. If you have a spina bifida occulta, they don't present unless they come with, very insidious onset clinical features. So therefore, they are to be detected by us. But if you have others which are seen on surface, it can be just a mesodermal structural change. So it gives you a hint, may not really show you very much. But in the severe ones, you can see meningocele, or you can have meningomyelocele, which can be ruptured or non-ruptured. Okay, so depending on that, you would have your clinical spectrum. How do they present, right? So it could be just, I mentioned, looking at it, you see it, or You can also detect it by observing loss of function, right? So loss of function would be the areas that are involved. I told you already, commonest site is lumbosacral region. So if you have something in the lumbosacral region, what type of abnormalities would you get? Anybody? What type of abnormalities would you get? Give me one clinical presentation. Anyone?
Fecal and urinary incontinence.
That's right. So you will have your sphincter involvement, right? So particularly if you have the lower sacral region involved, sphincter disturbances can be there. You can have limb involvement if you have the lumbar and the upper sacral segments involved. If you have the lower sacral segments, then the chances of you having a walking difficulty is less. So depending on the segments that are affected, you can have sensory involvement. And somebody already mentioned, yes, there can be loss of sphincter control. They can also have other associated. For example, they can have features related to a Kyrie malformation. I hope you know what a Kyrie malformation is. There's a tonsillar descent, right? So depending on the type, particularly with these neural tube defects, they invaginate outside. So therefore, your what phylum terminale gets stretched. It can get attached, and it can cause what you call tethering, and that can also cause a herniation, which is causing what you call a Kyrie malformation. Then you can also have effects on other tissues because your, not only your lower limbs, your hip muscles are weak, so you can have hip dislocation. If the lower lumbar nerve roots are affected with the upper sacral segments affected, you can have thallipus equinovarus deformity. Then, because we link to your previous understanding, you can also have hydrocephalus as the presenting feature, and you can have vertebral abnormalities as well. Of course, they can present with evidence of complications as well. So they can be the formulate a path for ascending infection. So obviously, if you are having visible abnormalities, it is detected at birth. If you don't have visible abnormalities, then of course, these may be some other ways how they present. So what are the important things that you need to evaluate? You already have diagnosed. You have to keep an eye on the head size. You have to look for other dysmorphism because it may be just part of the spectrum because it's a midline problem, midline back have problem, which means you can have other midline problems as well. You can have cardiac defects. You can have problems in relation to your, genital organism, for example, like, non-descent of testes. You can have palatal abnormalities because you can have other midline abnormalities as well. I already mentioned you can have other mesodermal structures abnormalities. So you may have to screen for vertebral abnormalities and then other complications, right? Vision, growth, they can also be affected. Your specific evaluations would include local evaluation to look to see what is the surface skin like. Are there skin abnormalities? Is the skin intact? Is there evidence of infection? Is there evidence of rupture and leakage? Is there evidence of dehydration? And then you look for specific abnormalities, like, of course, you have to look for the neurological deficits. You look for neurosurgical complications, urological, gastrointestinal, and orthopedic, and so on and so forth, right? So these, all of them, they don't happen at the time of birth because at the time of birth, often what you appreciate would be mostly the local effects, the ruptured meningocele. It's like drying and it may be bleeding and it's very likely, prone to get infected. So with that, let's try to understand how do you assess and manage. So obviously you can understand there's an early management and a subsequent long-term management. So let's start with early, meaning you detect it early or you try to prevent it. I already mentioned that folate deficiency is associated with risk of neural tube defects. So therefore, pre-pregnancy, because your neural structures are completely formed by the end of 8 to 9 weeks. So there has to be pre-pregnancy folate supplementation. We normally perform an anomaly scan, and then if you find something suspicious, you can confirm by performing a fetal MRI. And also, you from the early time period, you try to prevent infection, which includes maternal ascending infection as well. So we try to avoid a chorionic infection because it exposes the ruptured tissue to infection and therefore meningitis. And how we can minimize the damages to these exposed surfaces would be by performing early surgery, right? So now there is scope to perform fetal surgery as well. So whether we do it, that's different. But yes, there is, there are fetal surgeries being performed. So once they come out, you detect they come out. We if it is large, we deliver, by a section. If you think that we cannot deliver vaginally, and once they come out, we look for other complications. So complications would include avoiding infections. You monitor for development of hydrocephalus, then look at the disabilities. You manage the neurology, nephrology, bladder and bowel. Then orthopedic, and whenever required, we perform serial neurosurgical procedures. So initially it will be just a covering to prevent infection, and subsequently we may venture to do other neurosurgical interventions as well. Okay, so few words about surgery. Now, this is something I want to emphasize. Surgery will not cure the problem. Surgery is done only to cover it so that there is no further neurological damage due to drying or fraction or surface irritation. And also it prevents ascending infections. Okay, because otherwise, just like the parents, sometimes you might think that everything was covered at birth, so therefore there is not going to be any neurological deficit. You cannot reverse the neurological deficit, but you can minimize the neurological deficit. So that's why when the baby is born, it's extremely important for us to cover, avoid dehydration, avoid exposure to infection, and perform very early surgery. Okay, this doesn't happen. Instead, parents are told that it's useless, and then the baby eventually gets meningitis, and the baby suffers much more by just leaving it without attending to it, rather than prompt surgery and prevention of ascending infection. So it's not just one surgery. The neurosurgeon gets involved over and over several times. So there will be multiple surgeries which will be performed at different time points. Right. So long-term follow-up, I am quite sure you know that, anybody who has just a neural tube defect is as smart as you are, has full right to be just even the president of a country. So therefore, it's our duty to make sure we do this, prevent infection, minimize neurological disability, right? So these patients do deserve to be cared in the community with optimal management options. It should not be that there is no hope, there's nothing we can do, there's lots we can do, right? So, these are just broad concepts of rehabilitation. So, prompt care, rehabilitation, you have to have lots of modification, not only home, you have to have appliances, we have to support mobilization, we must have systems where mobilization is made facilitated, wheelchair access has to be facilitated, proper setups like toileting, all others which accommodate these children should be made available, and that should include long-term bladder care, bowel care, management of pain, and also so much of psychological support, right? So I've just put the principles only. When you see a patient, you will understand, right? So in brief, over the last 1 hour, we discussed, interrelated two important component. We discussed hydrocephalus, and then we discussed neural tube defects as a cause of hydrocephalus, and also through that we try to understand the spectrum of neural tube defects. Okay, right. So now a lot of important pearls delivered throughout the day, one after the other. But the two components that I mentioned, the infections, and now moving on to another aspect, all require early detection, prompt attention, minimizing infection, and very careful long-term rehabilitation. Okay. Right. So these are the learning outcomes. We venture to define and classify the hydrocephalus. I hope you remember how we do that. We describe the causes and clinical features of hydrocephalus. I told you the young ones, older children, adults, and then the elderly. We discussed how it can evolve depending on the type, and particularly in a child. Then we explained the pathophysiology of developing neural tube defects and the clinical features and discussed how to manage a child long term. Okay, right. Now you have to ask me questions. If you don't want to ask, please put in the chat box. Previous batches, they would ask whatever, ask questions or put in the chat box.
Madam, initially there was the MCQ stem where you told the shunt goes to the atria.
Yeah.
Is it to the atrium or to the pericardium?
You can have both, right? So you can have to the pericardium, and also ventricular atrial shunting is also performed. Okay.
Thank you, madam. Also, madam, when you were describing the differences of hydrocephalus like early and late, it's entirely dependent on when the sutures are fused, right? The distinction?
Yes, yes. The way how I described, yes.
Thank you, madam.
Yeah. Okay, so while you're thinking of questions and typing it in the chat box, I'll tell you the story of Poojan. He's actually one of my own patients, and a very interesting girl. She's she's a teenager, lovely girl. But let's try to understand what happened in her life. So Poojan is the second child born to a family where the mother actually suffered from epilepsy. Unfortunately, those days, at least most of the patients were put on older group of anti-seizure medications, and then she was continued on phenobarbital without being changed before pregnancy. So as a result, Poojani had a lower lumbar ruptured meningocele. So repair was done at 1 week, a bit delayed because 1 week is too late. I told you it has to be very early surgery. So as a result, it was complicated with meningitis. So here you have, if it is uncomplicated, you have only your lumbar and sacral problems. But here you get infected, and she had a meningitis. As a result, she had the rest of the brain involvement as well. So she developed hydrocephalus, and she was inserted a VP shunt by the age of 10 months. And as a result of her disability, she had a lumbar and upper sacral segment. So she cannot sit alone. She had developmental delay. She has hearing and visual defects. These are because of her meningitis. Then she has a neurogenic bladder, and she has been on continuous intermittent catheterization from the age of about 3 years. Bowel control is reasonably okay. She opens bowel once a day, so that's not so much of a problem. She does not have any form of movement below her knees, but she has some quadricep power, so she's able to sort of using clutches. She's able to stand. She has good upper limb muscle power, so therefore she's able to stand using the clutches. But most often she gets around with the use of the wheelchair for mobility. She has significant hip dysplasia that's also preventing her from achieving a good standing balance. She has schooled only up to the grade age of 5 because one thing, she had learning issues, but the more important problem is because of social issues related to toileting and inability to perform CIC within the school environment. Okay, so with that, I'd like to come to an MCQ. So can you again shout out the answers? Regarding neural tube defects, it occurs due to anti-seizure medication used in pregnancy.
True.
True. Lower the lesion, greater the difficulty in walking. Again,
False.
false. Yes, Ineth, why? Why do you say false? Your answer is absolutely correct.
s- like the upper segments are more likely to cause weakness in like the hip area, like which is more useful in walking. Like lower down, it might cause issues like in the feet. Maybe I'm not really sure, but
Okay, where would you think the lowest ones would be? In lumbosacral meningomalacia, you can have from lumbar region to the sacral region. So if you have a sacral region involvement, what would be the deficit?
more likely like bladder and bowel function rather than.
So sometimes they don't even have any walking problems, right? So therefore, you may not detect it. So you have to be, watchful if they, when patients come back with recurrent UTI, that is where we look for spina bifida occulta. Or you can see the lesion externally, but clinically they may not manifest anything. It may be just the bladder and the bowel dysfunction. Hydrocephalus is a complication that's easy. It is prevented by maternal vitamin B12 supplementation. Come on, true, false?
False. Folate is
Yes, not B12, it's folate. Bladder symptoms may not occur at birth. True or false? Anybody need to go? It's 4:38.
True, madam.
Yes, who said that?
It's
Is
me.
it wrong?
Yes,
Why?
madam.
Why?
Because at the birth already bladder incontinence is there.
Yeah, at birth, we don't even, you don't know whether the continence is there or not, right? The bladder, it opens at when the bladder fills, but it's very difficult to know whether there are bladder symptoms or not, right? So it may not be present at birth. So that's true, right? Okay, right. So again, coming back to the learning outcomes, this is what we discussed. We defined and we looked at all these different aspects that including hydrocephalus and development of neural tube defects. Okay, right. So are you useless? No questions. Hari. Okay, so next time, right? So tomorrow I will be talking to you about cerebral palsy. So it flows from, I spoke to you about infection and I told you it carries a lot of comorbidities. So cerebral palsy, one of the causes is infection, both intrauterine infection and then subsequent acquired infection. So tomorrow we will be talking about cerebral palsy. Okay? Right. Okay. So then I will stop here. Right. See you tomorrow.